Thank you, Bob and Forrest, Norma, the Butte County Healthcare Coalition, and the Chico, California PNHP chapter for inviting me today to speak at your annual members meeting about from the boardroom to the exam room, the privatization of public Medicare. I really loved everybody's comments up until now, and I hope that you'll learn something in the next 35 to 40 minutes or so. So our objectives for today are going to be to review the difference between traditional Medicare and Medicare Advantage and the march towards the privatization of Medicare, to understand something called value-based payment models and accountable care organizations and how they threaten to privatize traditional Medicare, to describe the California Office of Healthcare Affordability and how it promotes privatization of actually all healthcare in California, and then finally to take action to protect Medicare from privatization. So the first question that we should ask ourselves and to try to answer is, why do we care if Medicare is being privatized? And I believe that as single-payer Medicare for all healthcare activists, if Medicare is under threat, so is the dream of single-payer Medicare for all. The Medicare Trust Fund is being plundered. Wall Street is making billions off our payroll deductions. And finally, Medicare might not be there for us, for our children, or for our grandchildren. And that's why we must protect Medicare now, or there won't be any Medicare for all left to fight for. Now, we probably all know the term Achilles heel refers to a vulnerability or weakness. It is rooted in the myth of Achilles' mother dipping him in the river Styx to make him immortal, which you can see in this painting, making his entire body invulnerable except for the part of the foot where she held him, the proverbial Achilles heel. Thus was Medicare born, with a small but important vulnerability, the intersection of private insurance plans into this otherwise public program. Now, to understand this, let's start with a bit of history. As we know, in 1965, Medicare was passed by Congress and signed into law by President Johnson to cover the healthcare costs of seniors 65 and older, who were at that time almost uninsurable by private health insurance companies because they saw seniors as a business loss. And to accommodate the opposing factions, of which there were many, including the American Medical Association, President Johnson didn't just pass a single Medicare, he passed two Medicares, Part A and Part B, and then also came with a Medigap plan. And over the years, C was added, and finally D. Now, to go back over the different parts, the initial accommodation created Part A to cover 100% of hospital costs, and that's the reason why you see that little hospital icon on top of A. And that was provided by the US government and had no premiums. Now, Part B would cover outpatient costs, and that's the little icon there with the doctors, the x-rays, labs, and so forth, but only at 80% coverage, also provided by the US government, but with monthly premiums. Now, and as a result of this incomplete Part B coverage, Medigap was created. And this is a supplemental policy offered by private health insurance to cover the 20% of costs that Part B didn't cover. And this is the Achilles heel of Medicare, the first entry of private health insurance into a public program. And having allowed private insurance to operate in public Medicare, it became easier later to privatize Medicare through Part C, which was introduced in 1997 to manage care for seniors on Medicare to ostensibly, quote unquote, improve outcomes and lower costs, which we will see shortly, had been going up without pause since 1965. Now, Part C gave seniors the option to choose private health insurance to manage their hospital and outpatient costs, and that's why you can see the icon there of the hospital and the doctor together. That is, bundle Part A and B together. Now, in 2003, C was renamed Medicare Advantage, what we know it today, and that came with extras such as dental, hearing, and vision, but required narrow networks and prior authorizations. Remember, people with Part C, now called Medicare Advantage, still pay the Part B premiums. And in 2003, Congress passed Part D, another private health insurance option to cover some prescription drug costs. Now, Part A, B, and Medigap are called traditional or original Medicare. And Part C and D are called Medicare Advantage. Now, to complicate matters somewhat more, people on traditional Medicare also typically purchase a Part D prescription drug plan. And the dollar bills are to remind us all that Medicare Advantage is public money transferred into private companies through contracts with the Centers for Medicare and Medicaid Services, also known as CMS, and that is the definition of privatization. Now, I like to think of Medicare like a pie, which in 1992 looked mostly blue. That is, most beneficiaries were on traditional Medicare, and only a very small percentage, you see that little slice in green, chose a private health insurance company to manage their Medicare through Part C. What we will see in the next few slides is the forward march of privatization of Medicare. So in 2005, the percentage of beneficiaries choosing Medicare Advantage jumped to 12%. In 2010, the percentage jumped to 25%. By 2015, almost 1/3 of beneficiaries chose Medicare Advantage. By 2020, 42% chose Medicare Advantage, so that's all in the green. By 2024, this year is the first year that over half of the beneficiaries choose Medicare Advantage over traditional Medicare. By 2025, it is projected that 56% will choose Medicare Advantage, and by 2030, 60% of beneficiaries will be in that green slice of the pie on Medicare Advantage. Now, by the way, all the slides have references at the bottom, and even though it might sound like I'm making this stuff up, I am not. But rural communities look different than the Medicare pie in the United States. Here in Butte County, the pie today looks like the pie did in 1992. 91% of seniors choose Medicare Advantage. And in fact, in California, seniors who live in the light blue counties are overwhelmingly in traditional Medicare. And you can see those light blue counties, that's northern counties, eastern counties, central coast counties. They are choosing traditional Medicare, whereas urban seniors are more likely to choose Medicare Advantage. And I'm assuming some of you are on Medicare. And how many of you are on traditional Medicare? Yeah, this is very interesting, very different than the other talks that I typically give. Typically, it's the other way around. But in Butte County, it is different because rural counties, the seniors and people with disabilities choose traditional Medicare much more so. But across the country, more seniors are choosing Medicare Advantage. And the question is, why are seniors choosing Medicare Advantage? Well, it's cost. In 2024, seniors without any hospitalizations for Part A, B, D, and a Medigap plan pay on average about $6,557 per year. And that's compared to those on Medicare Advantage that are paying $2,100 per year. However, remember that with Medicare Advantage, you have to agree to narrow networks of physicians, specialists, and hospitals, and that 99% of Medicare Advantage plans include prior authorizations. Now, not only is Medicare expensive for seniors, it's also expensive for the federal government. And if we look at the Medicare budget here from 1965 to 2024, you can see that the Medicare budget, which in 1965 covering 20 million seniors was started at $10 billion per year, has been going up and up and up and up and up and up until today, where it covers 65 million beneficiaries, and the annual budget is $1,000 billion. So it's easy to understand why the federal government would want to find a way to control costs. Unfortunately, as we can see, Medicare Advantage has not done so. In fact, corporations have been making billions off Medicare for decades, and Congress knows this, CMS knows this, but how are they bilking the government? Well, Medicare Advantage plans are given upfront payments and those are called capitation payments for every beneficiary in their plan. And if they're given these payments for each beneficiary up front, they will want to select the healthiest patients possible. So they can keep as profit what they don't spend on care, and this is known as cherry picking. And they will also want to get rid of the sickest patients so they don't have to spend more than they get from Medicare, and this is known as lemon dropping. Now, they're also going to put up barriers to care. And in fact, an Office of Inspector General report showed that up to 13% of these prior authorizations requests that were denied by Medicare Advantage plans met Medicare coverage rules, and this is known as prior authorizations. They will add conditions that don't exist for healthy seniors, increasing that capitation payment, that upfront payment, and not spend a penny more on their care, and this is known as upcoding. And finally, a recent report from Physicians for a National Health Program estimates that Medicare Advantage companies are overcharging Medicare by as much as $140 billion every year, and this is known as fraud. Now, there is ample evidence that profit is bad for health. I'm just going to look at 3 institutions: dialysis, thank you, hospice, and nursing homes. So, as we've been talking about before, 95% of all dialysis centers in the US are owned by for-profit corporations, really 2 for-profit corporations. Patients at for-profit dialysis facilities have greater odds of dying than patients at not-for-profit facilities, even with similar health conditions. And as a result, over 3,800 excess deaths could be averted annually in the US if all dialysis patients were treated at not-for-profit centers. Further, 2/3 of all hospice facilities are owned by for-profit companies, many of them private equity firms. For-profit status at hospices is associated with fewer services, less clinically skilled staff, more formal complaints, more discharges of sicker patients, and more hospital and emergency room use. And finally, even the vast majority of nursing homes are owned by for-profit companies, and for-profit nursing homes skimp on nursing care and have more citations for quality deficiencies and have a higher death rate than nursing homes run by not-for-profit systems. Now, profit is also bad for the Medicare Trust Fund. The Medicare Trust Fund is actually made up of 2 parts. The Hospital Insurance Fund, which is funded by our payroll taxes. That's what we pay or paid into Medicare every 2 weeks, and that pays for the Part A benefits. And then there's the Supplementary Medical Insurance Fund, and that's funded by general revenue and Part B premiums, and that pays for the Part B and D benefits. Now, the more money that goes from the Medicare Trust Fund to corporations, the faster the funds will be depleted. The Hospital Insurance Fund actually is projected to run out of funds by 2036. Another way of talking about transferring public Medicare money to corporations is privatization, which is defined as the transfer of public funds to private hands. But profit is good for business. While seniors anguish between choosing a medication or a meal, the annual gross margins in the Medicare Advantage market are almost double the margins in the individual and group markets. Now, let me explain what that means. That means that insurance companies are making twice as much profit from sick, frail, old, disabled people than they are from healthy, young, working people. Yeah. In 2007, before the Medicare Advantage explosion, remember that our Medicare pie, only about 12% of seniors chose Medicare Advantage then. United Health Group, the country's largest insurer, had total annual revenues of $75 billion. In 2022, again, remember the Medicare pie, a lot more green, their annual revenues jumped to $325 billion. Certainly not all from Medicare, but Medicare has been called the cash cow by insurance executives. And for good reason. Medicare Advantage accounted for $361 billion of federal spending in 2021, but is expected to grow to $943 billion by 2031. So that's just going to be the Medicare Advantage piece of the Medicare pie. Now, when embarrassed into action, CMS will actually try to rein in some of those corporate profits. And this year, they ruled that the capitation payments, those upfront payments, I'm sorry that this is such small print, that the capitation payments for MA plans, the Medicare Advantage plans, will only increase by 3.7% next year. They also revised the prior authorization model a bit, imposed an out-of-pocket cap of $2,000 for Part D prescription drugs, and instituted some changes to the star rating program that pays plans more for being better than average. Now, the industry response was as swift as it was predictable. Lots and lots of belly aching, threatening to trim benefits, raise premiums, slash provider reimbursements, and exiting markets, such as markets here in Butte County, as a result of what they described as a slash in pay. One thing that they will never mention, however, is cutting profits, right, to offset these changes. Now, the reality is that the government is actually good for business. While some industry players are belly aching, others, such as the CEO of Sanford Health Plan, which is a small, mostly rural Midwest plan, when the CEO was asked, is there a certain part of the business where you are looking to grow your membership? He answered, we see the governmental space as an important area of our growth in the future. Of course, Sanford Health knows where the money will never run out, and that's the government. Now, until now, we've been looking at the Medicare Advantage pie, a piece of the pie. Remember, that's the green piece of the pie. But the question is, why leave $500 billion on the table, right? What about the other slice of the pie, the Medicare pie, that blue slice, the traditional Medicare slice, where almost half of Medicare beneficiaries still get their benefits? This is what the industry is targeting next, and this is where we will spend the rest of our time. Now, to understand how corporations profit from government programs such as Medicare, it's important to understand how Medicare pays doctors and hospitals, also known as providers. Now, in traditional Medicare, Medicare pays doctors directly for every service. This is known as fee-for-service, and if you're on traditional Medicare, you go to your doctor who performs the service, who bills Medicare for that service, and then Medicare reimburses the doctor directly for that service. It's very easy, very, very direct. Nevertheless, American health economists have been blaming this fee-for-service or direct payment of medical services as the reason healthcare costs have gone up without checks since 1965. They blame greedy doctors for ordering too many tests and greedy Americans for getting too much healthcare. Yet, the myth of too much care is just that, a myth. When compared to peer nations who all have universal health care, Americans skip care due to cost more. In fact, almost 40% of Americans report skipping care due to cost compared to peer nations, and this appeared in the Commonwealth Fund that just published this. So other peer nations actually skip care due to cost less, and who, by the way, pay their providers through fee-for-service, yet have better health outcomes and lower costs. The reality is that our healthcare costs continue to rise without check because of excessive profit, excessive prices, much higher than in peer nations, excessive administration, also much higher, and excessive consolidation. These, and not fee-for-service, are to blame. Nevertheless, health economists believe that the way to control costs is to move away from fee-for-service, where Medicare pays providers directly, to a model of capitation and managed care, where Medicare pays a middleman an upfront capitated payment per beneficiary to manage their care and then pays the provider and keeps whatever is left over that is not spent on care. This arrangement is supposed to incentivize the profit-seeking middleman to manage care, reduce overuse, and control costs. And the middleman, in this case of Medicare, is the Medicare Advantage plan. Now, in the case of traditional Medicare, to save money for Wall Street, Medicare, instead of paying the provider directly through fee-for-service, would do something called value-based payment. Pay a middleman an upfront payment, who would manage the care of seniors and people with disabilities and then pay the provider. The middleman would now be called an accountable care organization, also known as an ACO. And this is known as value-based care, and it's also called an alternative payment model. Now, where does this come from? Where does value-based come from? Well, from the Affordable Care Act, which, to save money, forced capitation and managed care, not only in Medicare Advantage, but also in traditional Medicare, and called it value. It did this by two pathways. One, which created accountable care organizations in a program called the Medicare Shared Savings Program, and another, which created the Center for Medicare Medicaid Innovation, also known as the CMMI, a center whose sole purpose is to run value experiments on seniors on traditional Medicare. Now, what is an accountable care organization exactly? Well, an ACO is a middleman, just like a Medicare Advantage plan, that accepts capitation payments for beneficiaries in traditional Medicare to manage their care, who agrees to meet certain value measures, and we're going to talk about value in a second, and share the savings with Medicare, what is not spent on medical care. Finally, seniors on traditional Medicare who choose to pay more every month to stay on traditional Medicare are assigned, without their knowledge or consent, into an ACO. Now, what is value? Well, of course, value is good. But if we're going to pay for value, we will have to measure it, right? Mm-hmm. And what services do we measure? There are over 10,000 CPT codes. Those are the codes that providers use to bill Medicare for their services. We can't possibly measure all 10,000, right? So we're going to measure certain values that are measurable. Now, what happens to the services not measured? Experience shows us that doctors stop paying attention to those unmeasured services and pay a lot more attention to the services being measured. They teach to the test. And it's not cheap. Physician practices spend about $40,000 per physician per year to report quality measures, not to improve them, just to report them. And if value can't be defined or measured, should it be the metric to reimburse and reward medical care? Well, apparently so. All value-based payment ACOs do three things. One, they all insert a middleman between Medicare and the provider to manage care. Remember, there was no middleman in traditional Medicare. They all use performance measures to increase value, however you choose to define and measure it, to financially incentivize doctors, putting the doctors on the hook to produce savings, and they all set up spending targets. Payments for every beneficiary, similar to capitation, and the ACO gets to share what they don't spend on medical care with Medicare. So let's find out, how do these shared savings actually work? Let's take an example. Medicare gives value-based company Good Profit $12,000 to take care of Mr. Smith this year. If the Good Profit doctor only spends $300 for a well visit on Mr. Smith this year, then Good Profit and the doctor save $11,700 and get to keep a certain percentage of that amount as profit. If, however, the Good Profit doctor spends $36,000 on Mr. Smith because he gets sick, Good Profit and the doctor owe Medicare $24,000, and how much they owe depends on the financial arrangement with Medicare. Value-based payments undermines the relationship between the doctor and the patient, making the patient ask, whose best interest does my doctor have? Mine or the ACO's? Oh, now, according to the CMS website, there are currently about a little over 450 ACOs serving 11 million beneficiaries, which means that about a third of the beneficiaries on traditional Medicare are already assigned to an ACO. And I'm assuming maybe some of you in this room are assigned to an ACO, and you might not even know it. An important study was recently published in the Journal of American Medical Association, and that found that ACOs were associated with net losses to Medicare up to $1.4 billion during their 9-year study period. So ACOs are not saving money for Medicare. Now let's look at the other pathway. Remember, there was that one pathway that went to the ACOs and the other pathway that went to the Centers for Medicare and Medicaid Services. Well, ACO REACH is the largest value-based experiment from the Innovation Center. In fact, over 2 million individuals on traditional Medicare are in ACO REACH entities. It started as direct contracting entities, or DCEs, under the Trump administration, and then was green-lighted by the Biden administration, which changed the name from DCEs to ACO, Accountable Care Organization, REACH, Realizing Equity, Access, and Community Health. They just changed the name and added equity. Not necessarily, I mean, they just put the word equity in there. Just like every other ACO, it inserts a middleman called an ACO REACH to accept capitated payments and manage the care for seniors on traditional Medicare. They're expected to meet value metrics, spend under the target, and share the savings with Medicare. Seniors are enrolled automatically, without their knowledge or consent, through their primary care provider. And to opt out, seniors must find another PCP. And I'm imagining it's really easy to do that in Butte County. Yeah.
Easier in Grove Medical.
So who are these new middlemen? Virtually any type of company can apply to be an ACO or an ACO REACH middleman, including commercial insurers. The ones that sell Medicare Advantage plans can also be ACOs, private equity firms, venture capital investors, for-profit physician practices, for-profit and not-for-profit hospitals, and health systems. And you can look at that source and read the names. Now, how well do the experiments out of the Innovation Center do? Well, not very well. In September of 2023, the Congressional Budget Office published a report on the value of value-based models and found that their models increased Medicare spending by $5.4 billion. And not only did their models increase spending in the first 10 years of operation, they will continue to do so into their second decade. So nothing out of value-based, either ACOs or these CMMI experiments, is saving money for Medicare. So value-based payment does not save money for Medicare. To summarize, we went from traditional Medicare, where Medicare pays doctors and hospitals directly, to Medicare Advantage, where a middleman sits between Medicare and the providers, to value-based payment, where another middleman, now called an ACO, sits between Medicare and the providers. But there is another set of players that are even more important than the ACOs, which are the Wall Street investors who fund ACOs like ACO REACH. They are flooding middlemen with new money. These investors, of course, aren't stupid. They only put their money where they expect big profits. So how does a company with a stated goal of improving care and saving money make enough profit to keep its investors happy? Well, ACO middlemen make money by maximizing revenue from Medicare, minimizing revenue spent on patient care, and enrolling more beneficiaries. And if this sounds familiar, that's because this is a Medicare Advantage playbook in traditional Medicare. Now, let's go through these one by one. To maximize revenue from Medicare, that is to get those higher upfront capitation payments or the value-based payments or the benchmarks or the spending targets, they do this by upcoding. By adding diagnoses to each senior, middlemen can get higher monthly payments from Medicare, but they do not spend a penny more on their care because the added diagnoses are phony. Now, this is all perfectly legal, okay? Middlemen minimize the revenue spent on patient care. Just like Medicare Advantage, ACO and ACO REACH entities are allowed to keep as profit and overhead what they don't spend on medical services. And this is a dangerous incentive to ration and restrict seniors' care. These financial incentives do not exist in traditional Medicare because there is no capitation in traditional Medicare. It's just fee for service. But how do these ACOs enroll more beneficiaries if the beneficiaries are not choosing the ACOs? Unlike Medicare Advantage, where seniors choose a Medicare Advantage plan, seniors and people with disabilities on traditional Medicare are automatically assigned to an ACO or an ACO REACH without their knowledge or consent through their primary care physician. And as I said before, the only way to opt out is to change your primary care doctor. And even worse, according to CMS, according to their website, which is right there, you can check it out, every beneficiary on traditional Medicare will be assigned to an ACO by 2030.
Oh dear.
Now, what's going to happen to the Medicare Trust Fund? Well, public funds in traditional Medicare are used to reimburse providers for medical services. In traditional Medicare, 98 cents of every healthcare dollar goes to healthcare and only 2 cents goes to administration. Now, in Medicare Advantage, public funds leave the trust fund and go to profit-seeking insurance companies. Now, only 85 cents of every dollar goes to healthcare and 15 cents go to profit and administration. But in ACOs and ACO REACH, public funds go to corporations, which threaten the solvency of the Medicare Trust Fund, because in some of these ACO arrangements, as little as 60 cents of every dollar go to healthcare and up to 40 cents go to profit and administration. And again, all the references are right there. Privatization of Medicare threatens senior choice, because all seniors on traditional Medicare will be enrolled into an ACO without their knowledge or consent by 2030. Senior care, because doctors have a dangerous incentive to ration and restrict medical care. Senior trust, because it makes the senior ask, whose best interest does the doctor have, mine or the ACO's? Right. And the Medicare Trust Fund, which will be unable to provide full Part A benefits by 2036. Public funds should stay in public programs for which they were created and not handed to greedy corporations or middlemen. Now, to go back to our Medicare pie, the privatization of Medicare through Medicare Advantage or through profit-seeking ACOs will mean privatized Medicare for all by 2030. So what should we do? Well, as we've seen, Medicare is under threat. The Medicare Trust Fund is being plundered. Wall Street is making billions off our payroll deductions. Medicare might not be there for us, for our children or our grandchildren. And finally, if we don't fight for Medicare now, there won't be any Medicare for all left to fight for. We must protect Medicare now. But how? Well, if you would like to do something right now, take out your smartphone. You can scan this QR code and you can sign the petition to President Biden urging him to stop selling Medicare to Wall Street. So that's one thing that you can do. The next thing you can do is scan this QR code and download a letter to your member of Congress. I know. Asking him to urge President Biden to put a stop to all value-based payment in traditional Medicare. Or you can just call the White House directly and leave a message urging President Biden to stop privatizing Medicare.
Every other day.
Every other day, right? You can't do it every day. He's busy doing other stuff. So, now, while you guys are all doing this, I'm going to tell you what we've been doing in California, which is really, really, really inspiring. In California, we have already started the fight. In September of last year, of 2023, as a result of hundreds of activists from CARA, actually from the California Alliance of Retired Americans, from the movement to end privatization of Medicare, and from many other organizations, the California State Legislature passed something called Assembly Joint Resolution 4. And what does that do? It made California the first state to go on record, and actually the only state to go on record, opposing ACO REACH and corporate profiteering in Medicare. So it was a huge, huge victory for us. So this was 2023. In 2022, the same California State Legislature passed SB 184, the California Healthcare Quality and Affordability Act, which established the Office of Healthcare Affordability, also known as OCA, with a mandate to slow healthcare spending, that's okay, that's fine, to collect data, and to enforce spending targets set at 3% for 2025 to 2029. And we're going to get to these spending targets in a second. And to promote something called high-value system performance through the adoption of alternative payment models, which we learned today, like 15 minutes ago, that these are value-based care models. So this is not just about Medicare any longer. It's about practically every doctor, hospital, health system, insurance plan, and patient in California. And then the third thing was to assess markets consolidation, which is a good thing, but other agencies are already doing that in California, so we don't really need OCA to do that. Now, there were some statutory requirements to slow down healthcare spending. To do this, OCA, and I'm just going to use OCA because the whole thing is too long, will enforce the 3% spending cap on over 700 healthcare entities in California. So that's what I said. That's practically every doctor, hospital, health system, insurance plan, and patient in California. And that will include millions of people in California. And how are these entities supposed to achieve these spending targets? Will they be given more resources, a global budget, single payer? No. Entities will be forced to shift away from fee-for-service to value-based payment, just like the ACA did, which they call alternative payment models. Something we know does not slow down healthcare spending. We know that. We have plenty of evidence from ACOs and the CMMI experiments. Now, as we will see, also entities failing to meet these cost targets are going to be fined. So they have huge incentives to keep these costs down. And as we will see, these caps will harm sick, poor, and people of color the most. And finally, regulating thousands of these value-based payment models will only add to administrative bloat and cost as if we didn't already have enough. So think about what this means. Healthcare entities in California will be fined if they spend 3% above their spending cap. Now, to set a spending cap, obviously, for over 700 entities in California, you must calculate the cost of every individual in that system, right? Otherwise, how are you going to come up with 3% above the cap? You need to have their cap, right? So that's number one. And to calculate the cost, OCA will use something called risk adjustment. And I don't want to get too much into the weeds because it's late, but Medicare uses risk adjustment to figure out capitation for Medicare Advantage and also for these benchmarks and for these spending targets as well in traditional Medicare. And typically what they do is they give you higher capitation for sicker patients and lower capitation for healthy patients. And unfortunately, that's where the upcoding comes in. So OCA has decided to avoid upcoding, they're only going to use age and sex and nothing else for risk adjustment. Now, I mean, it's good not to upcode, but honestly, it is. It's exactly that. Now, let's just put that on hold. They're going to have to meet spending targets using capitation and value-based payment. So we know that they're going to have to meet these targets using tools that are incapable of meeting those spending targets. And imagine that you are the CEO of whatever health entity we're talking about. Either it's a private practice with more than 25 physicians, it's a health plan, it's Kaiser, it's a health system, it's a hospital system. Which patients are you going to choose to cover? I mean, are you going to choose the sickest patients to cover? Because, I mean, how are you going to meet your target? You're only going to meet your target if you have healthy patients. And you're going to avoid all the sick patients, all the poor patients, and then anybody that has a tendency to be sick or poor. So that's what we are headed towards in California. And just so that we are clear, and we understand what OCA is talking about, in their Appendix A, which called for implementation guidance for APM, which is alternative payment models, which are value-based payment models, they said that they are encouraging design core model components to align with models already widely adopted in California whenever possible. And examples include the Medicare Shared Savings Program, ACOs, and the Realizing Equity, Access, and Community Health REACH program. So we know exactly what kind of value-based programs they want these health entities to use in order to meet those spending targets. I think you guys should continue this organization because it sounds like you have a long, wonderful history. But if you have any extra time, you can join the movement to end privatization of Medicare. You can visit your state legislature. Senator Dolly and Representative Gallagher, I'm sure want to hear from you.
We've talked to him numerous times.
Oh, good. You can talk to him you can educate them about OCA. Tell them to protect the health of patients in California and to end OCA now. Now, my email address, if you want to join the movement to end the privatization of Medicare, is annamalinow@gmail.com, so it's easy. And if you want to take down my phone number, 707-340-9522. The movement to end privatization of Medicare is made up of wonderful organizations across the state. We have great members. We meet once a month, the first Saturday of the month. In fact, our next meeting is this Saturday at 9 a.m. I invite all of you to attend where we're going to be talking about this specific issue.